Good afternoon, everyone, and welcome back to our afternoon session for the Tine Haworth Libin Cardiovascular Research Day. We are now going to start the second trainee speaker part of our program, and this portion is entitled Transformative Original Ideas Talks, or TOD talks or presentations. And the session is going to be moderated by our friend Dr. Satish Raj. Satish is an associate professor at the Department of Medicine, and his research interests focus on the role of the autonomic nervous system and blood pressure regulation, in particular, how fainting and syncope mechanisms may develop and impact patient quality of life. So with no further delay, I'll hand over the podium to Satish and let him introduce our speakers for the first, or this round of TOD Talks. Please, Satish.
Great, thanks Andy, and thanks for all of you that came back after lunch. It's always a risky proposition to let people out. So the next wave of sessions are known as TOD Talks. Apparently they stand for Transformative and Original Ideas, yes. I think it's a total coincidence that our director's name happens to match. I don't think anything of that's how it came up. We have 5 excellent presentations. The ground rules for those of you scoring at home are that each speaker has 8 minutes for their presentation and 2 minutes for questions. So start thinking of them as soon as they start talking. They have only 4 slides, so we have to see if they can milk 2 minutes per slide. They get points for dress. They get points for style. No, just kidding. It's all about the content, of course, all about the content. So our first speaker is Dr. Nelly Abdel Fattah from the Garul Lab, and her presentation is on a new form of inherited cardiomyopathy that leads to changes in heterochromatin structure in humans and mice. Nelly?
Okay, hello everyone. So sudden cardiac death, it's account for 50% of all death caused by dilated cardiomyopathy. So dilated cardiomyopathy, it's a form of cardiac disease which is characterized by contractility as well as systolic dysfunction. So the heart is unable to eject enough blood to the whole body, and that leads to a lot of complication. Genetic component of dilated cardiomyopathy account about 45% of the cause of dilated cardiomyopathy. Many genes has been identified, but few genes has been validated with experimental design and segregation analysis. And we are interested in identifying gene, as identifying gene is very important to early diagnosis as well as management, better management of the patient. So I'm just gonna talk about one of the family we identify mutation for this family. So this is multi-generation family have been recruited to study through an autopsy report of a female 40 years old that dropped dead on the kitchen table. At that time, all siblings has been recruited and investigated. And turned out they have a form of dilated cardiomyopathy with high arrhythmic burden, and they have left ventricular systolic dysfunction, as well as they develop cataract at the early age, around 4 to 5 years old. So at age of 40, they develop cataract and cardiomyopathy. So our aim was to identify mutation for this family, and we looked at the heart tissue from the autopsy, and we can see eosinophilic infiltration, microfiber disarray, and increased collagen deposition. It was very interesting. We looked under electron microscope. We can see abnormal nuclei, as well as abnormal heterochromatin aggregation at the periphery. So we exome sequence for affected, and then after many filtration steps, we identify a homozygous missense mutation in one of the inner nuclear protein lambda2 in a very highly conservative LEM domain. So our question is, this is our causative mutation. So what we know about lambda2, we actually don't know much about lambda2 except it's a homology of amarin. Amarin is a gene known to have a very association with dilated cardiomyopathy. Many mutation has been identified. And also it has a role in regulation of the cell cycle and mitosis. So we looked at proliferation rate using patient fibroblast as well as age-matched control and younger control at early passage and late passage, and we can see a significant delay in the proliferation in the early passage, and a late passage, the fibroblasts did not proliferate. Also, we counted the cell senescence using the patient fibroblast as well as age-matched control and an older control, and we can see there are increase in the number of the cell senescence in the early passage and a significant increase in the late passage. We counted the DNA content of each cycle using the patient as well as the two control. So we can see there are a significant number of the cells, they have been stayed at the G1 and they were able to proceed into S phase, which is lead to G1 arrest. So to get more information about the function of LMDA2 and as well as the effect of the mutation, so we create a knock-in mice using CRISPR-Cas9. So we have a knock-in line, which is the deletion of we deleted 2 amino acid and where the mutation, and this is in this line the protein is stable. In the knockout mouse, we delete 50 base pair from the exon 1, and that lead to outframe deletion of the exon 1, and the LMDA2 protein is absent. So for the knock-in mouse, they die at E11, and we cannot identify any homo after E11. At E11, they look smaller in size, and looking at histology, we can see they have abnormal developmental outflow tract, as well as the ventricle is underdeveloped, and they are thin comparing with the head. Also, we have really identified they have abnormal nuclei as well as heterochromatin aggregation in about 90% of the counted nuclei. For the knock-in mouse, so they die in an area between 16.5 to 18.5, and they show abnormal variable Mendelian inheritance at that stage. But once they pass the 16.5, they can survive until P21. So the embryo shows enlarged right ventricle and left ventricle. They have a very thin compact and non-compact layer. For the adult mice, they look smaller and tiny, and they have pale heart. And looking at their heart using histology, we can see they have also enlarged ventricle, and they have a very thin compact and absent of non-compact area, which suggests that this is something embryonic, early, abnormal proliferation during early development. And we looked at also both embryo and adult, they have abnormal nuclei with abnormal heterochromatin aggregation in about 90% of the nuclei. We looked also at some of the cardiac function using echocardiogram, and we found that there are 3 significant components has been significantly decreased: the ejection fraction, the fractional shortening, and the intraventricular septal thickness during systole, which reflect a decrease of the cardiac function of these mice. So I think we have identified a mutation that causes cardiomyopathy in this family, and the mechanism of developing of the cardiomyopathy in this family is not really well understood, but we think that the premature aging of the cardiomyocytes that could be causing cardiomyopathy in this family, so premature aging of the cardiomyocyte that lead to decreased contractility, enlarged of the ventricle, and developing of the dilated cardiomyopathy. And I would like to thank all the funding agency, thanks all the facilities. Thank you. It's too early, I think.
We have time for a few questions.
Nellie, thank you. Did any of the other family members express a cardiovascular phenotype and even have heart failure? Or did you have any evidence of left ventricular dysfunction in any of the other family?
There are another family has been identified with this mutation from Winnipeg, and they have a couple family members, they have heart failure, and there are 2 members, they have sudden cardiac death at age of 40. There are not other cardiovascular disease, no hypertension, no other phenotype has been identified yet so far. Welcome.
Any other questions?
Emily, do you have a sense of how widespread this particular mutation may be? Is it commonly found in, for example, in databases or?
It's a novel mutation. It's the first time to be identified in this family. And the gene also, it's very new genes to be associated with cardiomyopathy. It's a new gene. It's novel gene.
Thank you, Nelly. Do you have plans to look at maybe children of these? It sounds like we're using the siblings.
There are, I think, ongoing recruitment of those family members, and we don't have children at that time, but there are still this family recruited and other families to look at their, examine their heart and cataract. But they usually express cataract at very early age. This is what really more going to look at the cataract and then the cardiac function.
Wonderful. Thank you very much.
You're welcome.
It's a great start. So next up is Nadia Marouf, who's in the Ed O'Brien lab, and she'll be presenting her work on heat shock protein 25. To pick your favorite number, 25, 27, it's hard with heat shocks. But immunization against that and whether it abrogates atherogenesis in, I assume it's mice that are overactive, whose ovaries are out. I can't actually say that word. And the role of the PSK9 pathway.
So hello everyone. I'm going to be sharing with you a story that actually led to my research today. Since the 19th century, scientists have been reporting a sex difference in the prevalence of coronary artery disease that favors premenopausal women compared to age-matched men, and that this gap narrows and puts postmenopausal women at an increased risk for atherosclerosis and mortality from cardiovascular disease. Oliver and Boyd were some of the pioneers in this field in the 1950s and decided to follow young women that had to undergo either bilateral or unilateral ovariectomies due to gynecological complications, and confirmed in their study that indeed the women that underwent bilateral ovariectomy did develop premature coronary artery disease. So as more and more scientists around the world were publishing similar results, a new theory developed that estrogens are cardioprotective, which led to the launch of several clinical trials that were testing the efficacy of estrogens in cardioprotection. Unfortunately, two of these major clinical trials, including the Women's Health Initiatives and the Heart Estrogen Progestin Replacement Trial, disproved this theory, and in fact, the Women's Health Initiative was terminated prematurely because of concerns of cardiovascular events, including stroke, thromboembolism, and increased incidence of breast cancer and new onset dementia in some of the patients. However, if we think about it, although postmenopausal hormone therapy did not prove to be cardioprotective, there's still the enigma of why premenopausal women are relatively protected from cardiovascular disease compared to age-matched men. And the relationship between ovarian function and cardiovascular health remains to be fully elucidated today. And this is just an example of the lack of understanding the scientific community is experiencing today that unfortunately leads to the fact that women in Canada are victims of heart disease, and it is a leading cause of premature death that claims 1 in 3 women's death every 20 minutes, which stresses the need of more women-specific heart research. My research focuses on a protein called heat shock protein 27 that my colleagues showed to be a downstream foot soldier of estrogen, and that it has beneficial vascular effects. So in order to answer this question of whether heat shock protein 27 and its ortholog heat shock protein 25 remains to be atheroprotective after ovariectomy, I used an atherosusceptible murine model, which we subjected to either ovariectomy or a sham operation, and then further randomized to either monotherapy with heat shock protein 25, estrogen, combination therapy, or many controls. So I would like to share with you some of my results. Here in the top panel, we have representative aortas from some of the groups that we studied. And these aortas were opened en face and stained with oil red O to help us quantify the lesions. So as we can see from the bar graphs that is summarizing the lesion formations in different groups normalized to sham-operated animals treated with controls, ovariectomy does indeed lead to a 64% increase in lesion formation, and all the therapies managed to reduce this increase and add an additional reduction in lesion formation with the most dramatic reduction seen with combination therapy for about 72%, as we can see in the bar graph. I also looked at total cholesterol levels, and as expected, in the beginning, all animals had similar cholesterol levels before being randomized to either ovariectomy or sham operation and randomized to their to different treatments. As we can see in the black curve, which represents the ovariectomized animals that were treated with control treatment, cholesterol levels remains high, and then heat shock protein 27 reduces these cholesterol levels, and then the most dramatic reduction was seen in combination therapy, as we see in the red curve. It was important that I look at PCSK9 levels and what the effects of heat shock proteins have on this protein for two reasons. The first one is PCSK9 is a very important protein in the metabolism of cholesterol. And second, results from 5 large clinical trials around the world showed that monoclonal antibodies that are targeted against PCSK9 were more effective in men compared to women. So they reduced cholesterol levels by about 60% in men compared to 40% in women. So some of this data might give us a small hint of why perhaps women are not responding as effectively to this treatment compared to men. So as we can see from the bar graph here, animals that were treated with estrogen alone had an increase of about 60% in their liver mRNA levels, and this has not been seen with the rest of the treatment groups. I also looked at some in vitro experiments using human hepatocarcinomas expressing the PCSK9 promoter. And as we can see, estrogen treatment leads to a dose-dependent increase in PCSK9 promoter activity, which was diminished by the addition of a non-selective estrogen receptor blocker. So to conclude, menopause leads to an increase in cardiovascular complications and disease. And of course, we do have a lot of work to do, but hopefully I've convinced you, or at least sparked your interest, that we might have a potential new therapy that could be used in the future as a preventative intervention in postmenopausal women, and perhaps if we optimize the equation in the atherosclerotic patients in general. Thank you.
Compliments to the speakers for staying on time. That's my biggest concern. Any questions?
Yeah, thank you. 2 questions. Can you just explain to us the difference between heat shock protein 25 and 27? And then my other question is there a dose response with respect to how much of the heat shock 25 or 27 that you've given with respect to the changes you see on PCSK9?
So heat shock protein 27 is the human ortholog, and heat shock protein 25 is the murine ortholog. So I chose to use that one in mice because I didn't want to get reviewers coming after me. The second question, we are only using 100 micrograms for heat shock protein 27 because that is the dose that my former colleague showed to be effective and does not cause toxicity. The heat shock protein 27 or 25 that we are using has a certain level of endotoxins, so we try not to use high volumes of it so that we can protect the animals from dermatitis and other issues that arise in the long-term treatments. Thanks.
How often do you actually study these animals after treatment? Is there a limitation to the time course which would be simply effective? Or have you studied it for long?
So I conducted two experiments. The first one was 8 weeks of high-fat diet and treatment. And I have seen the most beneficial effects with heat shock protein 27 in that long duration. However, the animals developed a lot of dermatitis, and so it was not humane to keep them that long because they're on a high-fat diet that causes inflammation and other issues. With this particular study, I only studied it for 5 weeks. So, yes, in the previous study with longer treatment, it was more effective.
So how do you think the recombinant HSP25 is actually having this effect on PSK9? And why aren't you seeing an effect in the absence of estrogen?
Can you just repeat that question, sir?
So how do you think HSP25 is actually having this effect on PSK9 expression? And how come you don't see a difference in the absence of estrogen supplementation?
So the first question, we actually still don't know how. What we know is that both in vitro experiments and in vivo experiments show with Western blotting or mRNA levels that heat shock protein does reduce PCSK9 levels. We don't know the mechanism yet. I think some of my colleagues will be focusing on that next. And the second question was...
how come you don't see, so you see an effect when you have the combination therapy,
Yeah.
but you don't see a reduction in just HSP25,
Yeah.
suggesting that there's potential competitive effect between those two on PSK9.
Yeah. So, like I said, I think we think heat shock protein 27 does reduce the levels of PCSK9, and so that's why when we added combination therapy, which includes heat shock protein 25, it was expected to see this reduction in PCSK9. What I didn't tell you is that the promoter sequence of PCSK9 does have an estrogen response element. So when you're treating an animal or a cell with estrogen, it does increase this promoter activity, which leads to more PCSK9 to be transcribed and translated. Thank you.
Our next speaker is a master's student in Rob Rose's lab. It's Tristan Dorry, and he's going to be presenting his work entitled Elevated Phosphodiesterase Activity Contributes to Altered Sympathetic Signaling in Sinoatrial Node Dysfunction Following Chronic Angiotensin II Treatment in Mice. There was something in that title for everyone. The autonomic group, the renin-angiotensin people. Politically great title.
Everyone can hear me just fine? Okay, so recently my father was diagnosed with hypertension. Now, he's always been a pretty active guy, so when he got the news from his physician, he was a little bit shocked. He came to me later and said, you know, Tristan, I've always had this really low resting heart rate. Now, we know that resting heart rate is associated with increased a number of different health outcomes. Both abnormally high and abnormally low heart rates are associated with increased cardiovascular risk and poor long-term health outcomes. Now, resting heart rate is largely determined by a small group of cells outlined here in red called the sinoatrial or SA node. And while it's quite small, it's profoundly important for generating the timely and coordinated electrical signals that initiate each heartbeat. However, it's not always as straightforward as just understanding what resting heart rate is and that it's associated with increased or decreased cardiovascular risk. We know that athletes have incredibly low resting heart rates and are perfectly healthy, probably more so than many of us in the audience today. But in diseases such as hypertension or heart failure, the sinus node can become diseased and result in abnormally low and dysregulated heart rates, at least in part due to an inability for the sinus node to generate spontaneous action potentials. Now, the current treatment for this is the implantation of cardiac pacemakers. And this is mainly for the treatment of sinus node disease or sinus node dysfunction, also known as sick sinus syndrome. And it's an incredibly prevalent but poorly understood form of cardiovascular disease that results in abnormal heart rate regulation, abnormally low heart rates, and the potential for development of serious life-threatening arrhythmias. However, while cardiac pacemakers have made a profound improvement in cardiac parameters and quality of life in patients affected with sinus node disease, they still come with a substantial cost and a number of attendant risks, including the need for battery replacement, the potential for lead dislodgement, and the risk of infection. So this, in my mind, at least in part, calls for an improvement for the treatment of patients with sinus node disease. Now, the sinus node doesn't work alone. Both the sympathetic and the parasympathetic nervous system are critical in altering heart rate. We know that the reason that athletes have such low heart rates is due to enhanced vagal tone. However, when we activate the sympathetic nervous system, let's say we go for a run, we're going to increase heart rate through activation of beta receptors in the sinus node. Now, in patients with hypertension or heart failure, the patients can often have elevated levels of resting sympathetic activity. Now, this may seem somewhat counterintuitive since I just said that these patients also have low intrinsic heart rates. But what happens is that there can be a mismatch between the amount of sympathetic stimulation provided to the node and one's resultant resting heart rate. So to really get to the bottom of this issue, we have to understand a little bit about how heart rate is controlled within the SA node. And that's predominantly by a little molecule called cyclic adenosine monophosphate, or CAMP. And CAMP is a crucial secondary messenger involved in a number of critical pathways within the heart, but within the node is important for the increase in heart rate that we see during sympathetic activation. Now, this is great when we want to go for our run or if we're watching a horror movie. However, if the levels of sympathetic activity get too high, we can also be at substantial risk for arrhythmia. Especially if the node itself isn't functioning well, then increases in sympathetic activation may become even more problematic. So I'd like you to think about this. If you were feeling sick, and then I asked you to go for a run, you'd probably be feeling pretty sluggish and need to take a few breaks along the way. But the body has an interesting class of enzymes that are really critical for regulating cyclic AMP levels within the body, specifically within the heart. Now, you're probably all familiar with a very specific inhibitor of these enzymes. And this is the class of enzymes is called phosphodiesterases, or PDEs. And the inhibitor, as you're all very aware of, is sildenafil or Viagra. And this is a specific PDE5 inhibitor used to treat erectile dysfunction. However, within the sinus node, PDEs are extremely important in regulating heart rate and response to sympathetic stimulation. So for this reason, we developed a mouse model of hypertension and sinus node disease to replicate what we know to be true in individuals affected with hypertension and heart failure. So what we did was we took animals, mice, and treated them with the vasoconstrictor angiotensin II for 3 weeks to induce a state of hypertensive heart disease and sympathetic dysfunction and sinoatrial node disease. And what we saw was an increase in global sympathetic tone, although a slowing in sinus node action potential generation, which can be seen here at baseline. We also saw a decrease in the sensitivity of the sinus node to respond to sympathetic stimulants such as isoproterenol. However, when we inhibited global PDE activity, we saw an increase in beating rate because we're allowing cyclic AMP levels to increase in the heart. However, the response after the application of IVMX, which is a global PDE inhibitor, showed an abolishment of the diminished beating rate seen at baseline. So this is in part some evidence to suggest a higher level of PDE activity within the sinus node just at basal levels. And this could contribute in part to the diminished ability of the sinus node to respond to sympathetic stimulation. And this is important because the inability to respond to sympathetic stimulation or to raise heart rate in the demand to a stress is highly linked to increases in morbidity and mortality. Now, we're probably quite a ways from having alternative treatments for sinus node disease in doing away with cardiac pacemakers or having complementary therapies. But looking at specific subtypes of PDEs may allow us to target therapies for the sinus node in the treatment of sinus node disease. Thank you.
Questions?
Just when you talk about the capacity of different rates.
Yes. Yeah.
One of the intrinsic factors that affects this is thyroid states.
Sure.
I've studied this before, hypothyroidism, hyperthyroidism.
Mm-hmm.
Those are easy to diagnose. However, it turns out when you actually have heart failure, you can have a reduction in the expression of the thyroid hormone receptors without overt changes in the thyroid status. So I'm wondering, do you have any, in your model, do you actually have any plans to examine the impact of your treatment on, say, gene expression or anything like affecting the intrinsic factors beyond the phosphatase?
So yes, it's something that we'll be looking at, not necessarily in the context of thyroid hormones. I'm not overly versed in the research there, but we will definitely be looking at some of the pathways, especially in the context of autonomic signaling, that could contribute to changes in autonomic status in these animals, and as well, it's probably a multifactorial issue, not just to PDEs.
Yes, and I'm just thinking to one of the earlier talks today, which was atrial dysfunction, fibrosis, and other things that can impact excitability. So, is it going to be manageable in a case of background hypertension to identify patients for cyclic AMP an underlying cause versus some of these other factors that can slow down excitability or heart rate or complication, progression, etc. So, again, do you see how this perhaps could be exploited or maybe used as a screening tool to figure out if someone would benefit from a PD biomarker versus someone that just works on it?
Right. It would be developing a clinical test to assess levels of cyclic AMP specifically in the node would probably be quite difficult, especially since most, the assessment of cyclic AMP is usually done through assays, and the node doesn't have, we don't want to be taking pieces of tissue out of the node clearly and subjecting it to assays. But it's a good question, and I'm not 100% certain that, we would probably need to really think about ways to assess PDE function in different areas of the heart, since the regional expression of PDEs is very different in the atria versus the node versus the ventricles. So just assessing it from one region of the heart might not tell you what's going on necessarily in the SA node. So it's a good question. I'm not entirely sure.
Thank you, Tristan.
Great, thank you.
Still trying to figure out whether to go to the device clinic and now tell them that we have to give everyone a trial of Viagra before putting in a pacemaker. Our next presentation is a clinical research presentation by Ravi Ramal, who's one of our senior cardiology fellows. His supervisor is Dr. Deborah Isaac, and he's going to talk about rheumatic heart disease, and specifically the need for antibiotic therapy and the development of public health education programs in developing countries like Guyana.
Good afternoon, everyone. Thank you for allowing me to share my research here today. With a show of hands, how many of you ever had strep throat? Could I just poll the room? Wow. almost greater than 75% of the room. Good. So, it's quite common that strep throat is a run-of-the-mill benign condition here in Canada, the United States, and the United Kingdom. Strep throat is caused by a bacteria, specifically group A strep. This bacteria has a specific protein called the M protein, and once a patient is infected by this bacteria, the immune response, the body mounts an immune response to this protein. But interestingly enough, this bug is super smart, and it tries to evade being killed. So there are other tissues in the human body that resembles this protein, and they can be found in the brain, in the joints, and more specifically in the heart and in the valves of the heart. And when that immune response is launched against this bacteria, it's also launched against normal, healthy tissue, leading to acute rheumatic fever. Over time, acute rheumatic fever develops into chronic rheumatic heart disease. One of the major reasons why there's such a low prevalence in developed countries is because of the easy access to healthcare and antibiotics. And after the visit to your family doctor, most of us return to a relatively healthy, normal life after being infected with a benign strep throat. But what happens in developing countries? What happens in developing countries like Guyana, India, South Africa? There are numerous data to suggest that rheumatic heart disease can progress quite rapid in these regions, moving from acute rheumatic fever to clinical rheumatic heart disease all within 10 years, resulting in end-stage heart disease, heart failure, in the second and third decade of life, so affecting really young adults worldwide. So, is there a way that we can stop this? Is there a way we can stop patients from dying from rheumatic heart disease? So, our research really chose to identify and treat those at risk, particularly in a developing country like Guyana, where we could identify patients already affected by acute rheumatic fever and identify those with subclinical and clinical disease. So the question is, how would we do that? We know that once you've been exposed to acute rheumatic fever, the valves in the heart gives telltale signs that this bug has mounted an immune response to the heart. And specifically, it causes either a tight valve or a very leaky valve. And what we did is that we looked close to 5,600 echoes that was reviewed in the Guyana program to advance cardiac care. And this was an initiative set up by Dr. Isaac way back in 2012. And we looked through all the echoes that were done, irrespective of the indication, to identify these specific changes. What we found was that the vast majority of patients that had a confirmed diagnosis of rheumatic heart disease based on 2 reviews of senior echo doctors with level 3 training that confirmed the diagnosis of rheumatic heart disease on separate occasions, we found that the vast majority occurred in rural areas of Guyana. And on top of that, there was a huge amount of these patients, close to 90% of these patients, had no documentation of being treated with antibiotics. This is a condition that is preventable and curable with early intervention with antibiotics. And as we can see, in urban areas closer to hospitals, there is less cases of rheumatic heart disease, and there was a higher amount of antibiotic treatment. The interesting thing to note is that in our cohort, as compared to other cohorts in India, Africa, where they use echo to specifically diagnose rheumatic heart disease, in this cohort, it's at least 5 to 7.5 times higher than those other populations. So this identification would spur the need for developing a guided promotional public health education program in regions like Guyana, where there's promotion, particularly at levels in the rural community, looking particularly at simple measures, hand washing, good sanitation to prevent rheumatic heart disease. And then in our population of patients that have confirmed diagnosis of rheumatic heart disease, antibiotic programs need to be set up within these communities in which it becomes easily accessible, where they could have mobile clinics to rural areas to treat patients after being diagnosed with rheumatic heart disease with a simple echocardiogram. It is important that these programs, the development of these programs, can only occur with collaboration, like that with Libin, as well as with WHO and worldwide organization that can really limit and prevent the progression and complications of rheumatic heart disease, particularly in young patients. So next time you have a strep throat, just remember it's not a benign thing in developing countries. Thank you.
We have time for a couple questions.
Probably I may have missed it, but of your 5,603 echocardiograms, how many had evidence that would be suggestive of rheumatic heart disease? And of those, how many would have sort of severe or moderate to severe stenosis or regurgitation?
Right. So in that population, we actually had 74 confirmed echo findings of rheumatic heart disease. In addition to that, there was close to 50 probable rheumatic heart disease. And of those that had rheumatic heart disease, the vast majority, almost 70%, had either a severe valve lesion. Most common valve lesion, as you all will know, is mitral stenosis, followed by aortic stenosis.
I have a question about actually what is generally considered a congenital condition, but actually one of the theories linked strep infection with hypoplastic left heart syndrome. I don't know if you're aware of this theory, but basically the theory is that strep infection during pregnancy in the second trimester can lead to essentially mechanisms you described, antibodies attacking baby's left ventricle, which leads to hypoplasia and essentially eventually simple ventricle heart. And I wonder if in settings of developing countries, is it possible or is there any data of prevalence of hypoplastic left heart syndrome? Or such data to obtain?
Yeah, so interestingly, within that echo database that was set up by Libin, there are a few cases, I would say, of hypoplastic left heart. And to say the exact correlation between the two, I think we haven't explored that data, But we do know that the prevalence of rheumatic heart disease is much higher in this population. And the question is, I think it's a valid question that we should probably look at that in the future. Particularly in that echo base, there's a higher amount of hypoplastic left hearts.
Final question. Go.
So in your study, so from a diagnostic perspective, was exposure to strep confirmed by autoantibodies in the bloodstream?
Right. So based on, so that is definitely one of the things in working in a developing country where resources are extremely limited. We do have access to echoes, right? And based on the ASC guidelines, the American Society for Echocardiography, you can make a confirmed diagnosis of rheumatic heart disease based on the morphology. And they've actually outlined a number of series of diagnostic criteria that's going to tell you that this is very likely to be rheumatic heart disease. And that's why we had to have 2 independent echo docs, past level 3 training, quite seasoned in making that diagnosis.
And just another follow-up question. So do you think a vaccination approach would also be effective in actually preventing this from actually developing in the first place?
So I think that is possible, but in this country, and I think in developing countries, it is, I think you'll have a bigger bang for your buck if you were able to develop educational public health programs telling these people what to look out for, what to avoid, and when to seek treatment, particularly getting antibiotics. Definitely, I think development of a vaccine may be beneficial, but again, how are you going to reach that vaccine to people who are far out in rural areas of developing countries? So that's what put a limiting factor.
Our final Todd talker is Cindy Kalenga, who's a master's student in Sophia Ahmad's lab. She's continuing the angiotensin and estradiol themes that have permeated through the other talks and combined them. And her talk is entitled Estradiol and Angiotensin II Responsiveness in Women Throughout the Menstrual Cycle. Cindy?
Is this the clicker? Yep. So as any child instinctively knows, moms can do anything. It's in their job description. They are full-time chauffeurs, our personal chefs, and more often than not, our cleaning ladies. Our moms are real-life Wonder Women. And so we don't ever think they can get hurt. Well, the single greatest health threat facing women today is heart disease. Heart disease is the #1 killer in women and affects 10 times more women annually than breast cancer. Historically, heart disease was thought to predominantly affect men. And so 2/3 of clinical research was done in men, by men, and for men. Fortunately for all, in the last 50 years, we've seen a dramatic improvement in mortality rates by heart disease. However, there is one group in particular in which we see no improvement, and this would be young women between the ages of 25 and 40 years old. This has prompted us to ask, what is going on in women? Why are more and more of our mothers, sisters, and spouses being affected greater than any other demographic? This question has led us to look at female-specific risk factors. Let's take a step back and recap the relationship between estrogen and cardiovascular health in women. As for some time now, we have known that estrogen plays a cardioprotective role in young women. However, when estrogen levels decrease at menopause, we see a dramatic increase in cardiovascular risk. And so previous studies, including the Women's Health Initiative, believe that if we supplement estrogen in post-menopausal women, we can restore their protection against cardiovascular disease. Contrary to what many people thought, this hypothesis was wrong. What they discovered is the women in their study who were on postmenopausal therapy had higher rates of heart attacks, strokes, and cancers. And one of the many discoveries that we got from this study was the idea that endogenous estrogen, what our body produces naturally, and exogenous estrogen, in the form of hormone therapies, do not have the same effect. In fact, synthetically derived estrogen has been associated with adverse cardiovascular outcomes. And so, what we've done is we've looked at a very common form of exogenous estrogen, and that's in contraceptives. And so contraceptives are the most widely used medication amongst Canadian women. Although it is safe for the majority, it does pose some risks. My research looks at the association between birth control and heart disease. Birth control increases a woman's risk for having a heart attack. For most women, this risk is small, especially if you do not smoke and you are not obese. However, contraceptives, when taken orally, activate the renin-angiotensin system and increase angiotensin II levels. Angiotensin II is naturally circulating in our bodies and is responsible for squeezing our arteries and increasing our blood pressure. Studies have shown that women who are on birth control, specifically the pill, have higher than normal angiotensin II levels and greater arterial stiffness, specifically pulse wave velocity. Unfortunately, these studies did not control for confounding variables such as the dose of estrogen, the type of progestin, and the duration of contraceptive use. Therefore, because of the presence of these confounding variables and the limited number of studies that actually look at the relationship between contraceptives and heart disease, it's very difficult for us to say with confidence how much women are at risk. My research looks to measure arterial stiffness as a surrogate marker for cardiovascular risk in women on many types of contraceptives, be it orally through the pill, non-orally through the IUD, the patch, or the vaginal ring, and no forms of birth control. The type of birth control that is associated with stiffer arteries is believed to be more dangerous. In addition, we would like to know, do oral contraceptives increase angiotensin II levels greater than non-oral forms? Is the route of administration increasing cardiovascular risk? We started by looking at women on no forms of contraceptives. So during the menstrual cycle, estrogen levels fluctuate, and we have what's considered the low estrogen phase and the high estrogen phase. We recruited healthy premenopausal women and measured their arterial stiffness at these two phases of the menstrual cycle to see if there was a significant difference. We observed no difference. In the next phase of our study, we are recruiting women on oral and non-oral forms of contraceptives and measuring their arterial stiffness. We hypothesize that women who are non-oral forms of contraceptives will be at lower cardiovascular risk than women who are on the pill. Now, it's very important for me to mention that contraceptives are incredibly effective, and by no means is the remedy for heart disease in women to completely abolish birth control. Rather, we've noticed that women are the only demographic in the last 50 years who have not seen an improvement in mortality rates. It is imperative that we look at risk factors that are specific to this population. These include things like pregnancies, complications at pregnancies, preterm delivery, and contraceptive use. Young women between 25 and 40 years old have a high rate of contraceptive use. I hope that through my research, we can evaluate the risks and benefits of the many different types of birth control and allow women to make an informed decision about their health. Thank you.
We have time for a few questions.
So what about exogenous estrogen versus endogenous? So what about the molecules different that it may exact different responses within the form?
It's a great question. So exogenous estrogen is slightly different structurally than endogenous estrogen, and it's not just that's the issue. It's the way that our body processes it. So when we take estrogen orally, it's metabolized by the liver, and that's where they believe it's activating the RAS system.
So intrauterine delivery or subcutaneous depot delivery would be better?
Sorry. Oh, yes, yes, it will be. So we hypothesize. There's been a recent study that has looked at non-oral forms of contraceptives and saw that there was no cardiovascular risk. And so that is one study that has looked at that, and there's very few studies that actually look at this relationship. And so we hypothesize that non-oral forms will actually be better.
See, I may be mistaken. Hopefully I'm correctly. I thought some of the earlier studies, late 90s, early 2000s, looking at hormone replacement therapy, that effectively concluded it was in fact they were even adverse in terms of effect. I thought we broke that group down into women that were early versus late menopausal, that the hormone replacement actually worked if you were within the window of 1 to 2 years post-menopausal. It didn't work 5 to 10 years post-menopausal. So is that sound correct? And if true, is it the timing in terms of replacement that is important versus whether there's replacement or not?
Yeah, absolutely. That's absolutely right. The timing of when we're giving these women estrogen is seen to be what's causing their adverse effects. What that study specifically, from my understanding, it was women who were just a little bit post-menopausal, where they saw a benefit, but older it wasn't. We haven't been able to elucidate exactly what is happening in the situation. However, this population was unique because they were already post-menopausal. We're looking here at women who are premenopausal, so they're making endogenous estrogen just fine. And so we find that when we give them exogenous estrogen, we are finding that there are some adverse effects.
Final word to Tine.
Cindy, thank you very much. So if I understand your abstract correctly, you studied about 10 or so normal women at 2 phases of their cycle who were not on replacement. Can you just remind us how many different replacement groups are you going to look at, and how many per group are you going to need to try and show whether there's differences?
Absolutely. So we've broken it down into 3 groups. So we've done already the women who are on no forms of contraceptives, and then we're looking at oral contraceptives and non-oral. So we need about 20 individuals in oral and non-oral in order to see a significant difference. Mm-hmm.
I'd like to thank all of our TOD speakers. I think they all did a great job. And I feel the need to applaud again. So one more round of applause. And I'd like to thank you all for hanging out and sticking in here. And if I'm not mistaken, I am keeping you from coffee and food right now. So have at it. Thank you.